Hello and welcome everyone. This is Dr. Tom Chaney and this is Living Health Live. Joining me on the show as well as in life and in our practice Living Health Integrated Medicine is my wife, Dr. Steph Chaney. We are your trusted source for the latest information to help you get and stay healthy naturally. We're super excited to be joining you on this regular journey, your journey of a lifetime, your lifetime of great health. And on this podcast, you're going to get some great information, some strategies, and we're always looking for the latest research to share with you so you can learn how to live a better, healthier life. Just a quick disclaimer, this information is intended for educational information only. Information is given here is designed to help you make informed health decisions and not intended as a substitute for medical treatment. So on today's episode, we want to talk about neuropathy. This is a topic that we see in our office quite regularly. So we're going to talk about what is neuropathy. We're going to go through and discuss some of the signs and symptoms. So you know if you have neuropathy or not. We're going to go through some of the top causes that we see in our practice. You know, one of the things we want to look for when patients come in with any condition in our practice is we want to look and identify the root causes and address those root causes. We're going to talk about some of the top causes of neuropathy. And then we're going to go through conventional treatment for neuropathy, what most patients are coming in and seeing us, and they've been to other doctors, what they're getting from outside of our office, and then how we approach it and what kind of treatments and therapies we provide in our office. So, Dr. Steph, what is peripheral neuropathy?
So, peripheral neuropathy is damage to the nerves or any disease affecting the nerves outside of the central nervous system. So you have your brain and your spinal cord, right? And that's what comprises your central nervous system. And it's all very protected and it's inside the skull and the spine. And once the nerves come out of the skull and the spine, they are now in the peripheral part of the body. So peripheral neuropathy is the death and dying or damage to the nerves outside of the spinal cord. So we have a lot of body that can be manifesting is issues with the nerves in the legs and the feet. It can be arms and the hands. It can be the torso. So that's going to be different than stuff that's happening inside the central nervous system. It can even be facial, right? So we've got cranial nerves. We've got nerves that come outside that are part of the peripheral system. It's different than central nervous system damage, which is going to be more associated with named conditions like multiple sclerosis, ALS, Lou Gehrig's, Parkinson's, Alzheimer's, dementia, things like that. This is going to be more related to, and usually more felt in the far areas of the body. So what are called the distal areas. So the fingers, the toes, areas like that.
Right. And usually it will start more distally and then work its way closer to the spine or up the extremity. So that's typically what we see. Usually it's symmetrical, not always. The other thing that, going back to this definition, damage to or disease affecting nerves. Now, that's not black and white. So patients come in and they've been to other providers and they've been told, well, you have neuropathy. And it's like the nerve is dead, right? And they're told that there's no way you can rehab or improve it. Now, there can be a point of no return, but for those of you listening, there is a spectrum here, right? There is a spectrum, and we see patients coming in at all different phases or all different parts of that spectrum.
Yeah, I mean, you've got to have neuropathy that ultimately leads to permanent is going to take a while. Usually it's a slow process unless it's trauma and the nerve has been severed, right? And there's many, many causes, which we're going to get into. And really, depending on the cause, will sometimes determine the speed or severity or where you will find it located usually. It's also usually going to be systemic. So it's usually going to be both feet or legs. It's going to be usually the toes in both feet, the hands and the fingers in both hands, things like that. A little more symmetrical when it's peripheral neuropathy. And that's to distinguish between, for example, someone having a disc problem in their low back, causing a radiating pain that they may feel in the foot or shooting down the leg, but it's usually unilateral in that case, meaning one leg. So if somebody has nerve pain or shooting pain happening in one limb, then we're more often going to look closer to the back, the spine. Whereas a true peripheral neuropathy is usually a systemic related condition. So, and what's happening in these cases, again, depending on the condition, either the blood flow to the nerve is being completely choked off or blocked. So that starves the nerve ultimately. And it can't maintain the protective sheath. There's a sheath around the nerve called the myelin sheath, which is very fatty, cholesterol-based protection. It's a bit of an insulator that allows the nerves to conduct messages from your thought right down the body at almost 300 miles per hour. You know, it creates these, there's very little actual raw exposed nerve fiber. So either that's being starved and the nerves are being starved by the blood flow being affected, or there's chemical toxicity, poisoning the distal areas, the delicate tissues, or the immune system's attacking. And we'll get into those kind of mechanisms a little bit more as we go along here.
Yeah. So that's what neuropathy is. So let's talk about some of the common signs and symptoms that you have neuropathy. And there's 7 common symptoms I see that patients come in complaining of. And we'll just go through these and then talk about them. But numbness is a common one. Burning pain, that's another one. Cramping, so muscle cramping. Sharp electrical pain, prickling and tingling. Balance problems is a big one. Even a history of falls. And then a lot of patients come in complaining that they can't sleep because of the foot pain. So these are all some of the common signs and symptoms. And you can see there, it's a wide ranging number of symptoms. And the reason why is different nerves carry different types of signals.
And really part of our evaluation of each case is to determine, for example, balance problems. Well, is that a brain problem, or is that a peripheral nerve problem? Like, are you not able to feel the floor with your feet, so you don't know where you're at, so you have balance issues? Or do you have an actual problem in the brain that could be affecting your gait?
Right. And then as well as, for example, numbness. So a lot of patients come in and they have, they can't feel their feet. You know, they can't feel walking around the house. So one of the things that I've had patients come in with, and they've been walking around the house bare feet, and they step on something and they can't feel it. So when you're numb, you don't have any sensation, right?
Correct.
And so I've had patients that have been in that position where the nerves are not working. So they have this numbness, and then they step on a little, maybe a shard of glass or maybe a little splinter, and they don't feel it. And I've had patients wake up the next day looking down at that toe, and that toe is turning colors.
Yeah, infected.
Right.
Yeah,
exactly. So that's why you want to really take this seriously. And if you have even the slightest symptoms, you want to figure out, well, what's going on and what's causing that.
And the main reason is that it starts slowly, right? So there may be the pain that the patient's not sleeping well. They feel this sensation of burning or tingling or whatever it is. And that's what's going to usually be sensed before complete numbness. And when you've completely lost sensation, that's becoming more serious, right? So the earlier you handle it, the earlier it is to fix, the faster we're able to work on helping your body heal. The nerves take a while to heal. And you just don't want to get it to the point where whatever is causing your neuropathy becomes a permanent damage to the nerves. And so you don't want to just, like you said, you don't want to sleep on this condition. You want to be taking action to reverse it during a time where the nerves can heal.
Right. So these are some of the common signs and symptoms and some of the complaints that we hear from patients coming in that have neuropathy. Now let's talk about some of the top causes of neuropathy. So the number one cause is diabetes and prediabetes. That's probably 30 to 40% of the cases that come into our office.
Yeah, in these cases, most of the time, these are not well controlled, or they've had diabetes for many, many, many years. And one of the issues with the diabetics is the circulatory problem, right? So the poor circulation in this case is a result of the diabetes. So when sugar gets too high, the analogy we like to use is that it's like the blood starts to become like barbecue sauce. It just becomes thick. It becomes sticky. Cells become sticky. They start clotting, and blood vessels can start to get damaged. And so the blood supply to the nerves over time becomes affected. There's also an issue. What we're finding now more in the last 5 or so years is some of the medications that diabetics are put on. We've done a whole podcast on this, the Ozempics, the Wegovy, the Rybelsus, Mounjaro. These are all a class of medications that actually, unfortunately, can lead to peripheral neuropathy, even in well-controlled sugar situations. And they don't only cause neuropathy in your feet, but they also cause neuropathy of, for example, they cause paralysis of your whole GI tract. So it's like having neuropathy of your gastrointestinal system. And that's how they work for weight loss. That's how they work to help with the whole sugar situation, by making you feel full. Longer, it's one of the things that it does is it actually stops or slows the stomach from emptying. So it's like a paralysis of your GI tract. So that leads to a whole bunch of complications, including higher risks of cancer. But I'm seeing more and more diabetics with neuropathy that don't have uncontrolled, crazy high sugars and hemoglobin A1C, but they may be on these medications. So a lot of the medications that diabetics are put on contribute to and can cause neuropathy, including the statins, the cholesterol-lowering medications, right? Mm-hmm. And I think the reason why more than half of the neuropathy patients are diabetic is because it's not just the sugars, it's the sugars and the medications and the toxins and all these other things that happen with a diabetic. Like, for example, the next thing on the list is poor circulation. Right. The next most common is toxins, heavy metals. We have a lot of patients that have had chemo, radiation therapy, both very damaging to nerves. Chemo in particular, a lot of heavy metal toxicity. I mean, these are poisons that are designed to kill the cancer. And they also are so toxic they kill our own body. And so while someone, for example, may survive the treatment for breast cancer with the chemo and radiation, they end up with neuropathy. And so in that regard, obviously, our approach is going to be different than it would be for a diabetic. Some people have post-surgical issues where the nerve was damaged higher up because of a back surgery or local surgery that damaged the nerves. So there may be some localized issues with that. So
I put the back and neck herniated disc and spinal stenosis and post-surgical, just so that everyone knows that we often have to distinguish between like a true peripheral neuropathy and is it a disc issue or a spinal issue, and making that differentiation in the office. That's something that we commonly have to do.
Yeah, so there's really three big categories of nerve damage that we're differentiating between. There's the actual peripheral distal nerve issue. Then there's the spinal. Is it happening at the spinal level? So is the peripheral nerve being damaged at the spinal level? Just so you guys can conceptualize that, let's say that the sensory nerve that gives feedback to the brain that there's burning and sensations and stuff happening in the toes. Let's say a nerve is damaged at the spinal cord, but that nerve fiber is what sends that message from the toes. Then the brain is getting the message that there's something happening in the toes, but the damage may be actually higher up in the spinal cord. So this is where we get into, like, usually that's one-sided, one leg, one foot versus the whole body being affected. So there's the peripheral, there's the actual nerve, being damaged at the location because of circulation being poor, low oxygen, low nutrients damage. Or is it spinal, higher up with that nerve, or is it an actual central nervous system brain problem?
Yes.
So those are the three big categories we're having to rule out. And
it could be a combination.
People can have multiple things. So very often we've got patients that have had, that have lots of serious issues in the back. Some patients have had failed back surgery and it may be more central nervous system. So they may have underlying early Parkinson's and not know it. And it was presenting in a way that they were worked up and diagnosed to have back surgery because they incidentally also had herniated discs. And believe it or not, people can have really severe degenerative issues and herniated discs in the spine and have absolutely no pain or nerve damage whatsoever. So just because something shows up on an MRI does not mean that that is the cause, right? So they have back surgery, they get fused, and they still have the symptom or worse because it might have actually, they might not have been worked up appropriately by the ortho or neuro surgeon. So the other really more and more common that we're seeing these days is like an autoimmune situation. So this is where their immune system is now triggered to actually attack and destroy the nerve, either the myelin or the nerve itself, the protein in the nerve fibers, or they've got like a circulatory autoimmune issue. There's something inflammatory happening. Mm-hmm. We've definitely seen an uptick in this since COVID. Some of our long COVID patients, neuropathy is a factor because of the effect on the immune system and the spike protein, and of course the COVID vaccines, many vaccines. There's many triggers to the immune system attacking. And so we see a lot of that happening. And concurrently, we see viral, bacterial, parasite activity also being a factor, which could be an underlying. Go ahead.
I was going to just going to infection. So we see a lot of patients in our area with Lyme disease, mm-hmm. and that's a common symptom of Lyme is neuropathy.
Yep. And again, that's triggering the immune system to attack. It can be an issue with the toxins associated with the waste products or metabolic products of Lyme, bacteria, yeast, fungus, parasites, viruses. Viruses, in essence, are a biotoxin. So a toxin's a toxin from a living thing. And the toxin itself can be in circulation and gunking up the system and causing the immune system to attack. So, and that can happen in these cases to the peripheral nerves or also the brain. So, and it's one of the common causes of chronic fatigue. So we have patients now coming in with excessive chronic fatigue, peripheral neuropathy. You may have been diagnosed because you're not diabetic. You didn't have chemo or radiation or trauma. You may have been diagnosed, for example, as idiopathic polyneuropathy. That's fancy talk for we don't know what's causing your systemic neuropathy. And polyneuropathy is saying it's many nerves being affected. So often these cases are younger, non-diabetic, and they have the sensations of burning and tingling in both their hands and their feet, possibly. So a brain fog can also be another kind of systemic thing. These are more systemic issues. So sometimes patients come in and they think they have neuropathy in terms of like a classic quote unquote, diabetic type neuropathy. And it turns out their underlying cause is actually MS or an autoimmune disease that is affecting the peripheral nervous system. I think we see this less now, but alcohol abuse is obviously a factor. I mean, nerves can literally just deteriorate because no different than the brain, because of the toxicity of the alcohol. And
its effect on these other organs, so causing liver disease and other stresses on the body.
But a lot of the toxins from the processing of the liver of the alcohol in the system, the formaldehydes, the aldehydes, all of those things are very toxic and tend to end up robbing the body of a lot of the nutrients that they need. So the vitamin Bs, the good fats. This is what over time leads to the demyelination of the nerves in the brain, as well as the peripheral issues. So that goes to liver disease. So there may be some non-alcoholic related liver disease. One of the more common causes of fatty liver disease is actually not alcohol, it's diabetes. So, you can see how a lot of these things can be connected. Kidney disease, which again, we see pretty high prevalence with diabetics. Thyroid conditions. So thyroid issues, many times, thyroid conditions actually have an underlying autoimmune component to it. And so that can be a factor. Or if your thyroid is not being regulated properly, or you're not compensating with the proper amounts of thyroid medications and things like that, that can also play a factor. And then we talked a little bit about medications, but the weight loss diabetes medication category of GLP-1 medications like the Mounjaro, Ozempic, Wegovy, those all can contribute to neuropathy. The cholesterol lowering medications of the class that are called statins. So, all the statin medications, basically, your nerves are coated in cholesterol lipid-based protective sheaths. And when you are driving cholesterol very low with medications like with the statins, then that drives hormones low, and it drives your ability to transfer and transport fat to these peripheral nerves gets affected. A study just got published. We saw that about a week or two ago that has unequivocally proven that there's a much higher chance of developing dementia if you are on statin medications. So we are definitely questioning, I see people having their cholesterol driven so low in the blood that I know that they're starving their brain, their endocrine system, and their peripheral nerves. So imagine you have a diabetic who's got the complications of sugar in the blood on a statin medication, lowering cholesterol and starving the nerves more. And then they might be put on one of these Mounjaro type, Ozempic type medications that cause even more degradation to the nerves. So then you've got this perfect storm of complications, including peripheral neuropathy.
And you can add metformin to other medications that can cause issues, because metformin long-term use has been shown to deplete the body of B vitamins. So you need those B vitamins for those nerves to be healthy.
Yes. And then other medications that cause major issues to brain and nerves in terms of the depletion of magnesium and B vitamins are the proton pump inhibitors. So these are the stomach acid reducers. So they're You know, a lot of people are told that they're producing too much stomach acid. We need to reduce your stomach acid, when in fact, they're actually not producing enough to effectively digest and move the food. And so they have reflux. They might have reflux because they're on Ozempic. Food's just sitting there and rotting and off-gassing sulfuric acid all the way up into the esophagus, causing burning. So then they're given an antacid, and the antacids actually, you need really high stomach acid to properly break down and absorb B12, which is so critical for brain and nerves, as well as important minerals like iron for delivering oxygen to the brain and nerves, as well as calcium and magnesium. So lots of medications will be contributing to peripheral neuropathy. And I will tell you, if you have peripheral neuropathy, if you have neuropathy in your hands and feet, you probably also have neuropathy happening in the brain as well.
Yeah, you just don't have the same receptors in the brain, and you're not going to feel it the same way. Mm-hmm. So most patients that come see us, we're not the first provider that they see. They have these symptoms that we talked about. So they may have pain that takes them into their primary care doctor. Their primary care doctor then may do some testing, or if they're not comfortable handling the case, they may refer them to a neurologist. Many patients that come see us, they've already been to a neurologist and they get testing done. So a lot of times they'll get what's called a nerve conduction test performed. I'm going to see how well those nerves are firing, and they get diagnosed with neuropathy. And if they're diagnosed with neuropathy, whether it's your primary care or if it's a neurologist, typical solution is going to be medications. And
yeah, it's standardly and literally this is it. This is the conventional treatment for this issue. It's gabapentin, which is an off-label use of a anti-seizure medication, basically. It acts on the brain, or an antidepressant, one of which is Lyrica or Cymbalta. Those are two very common medications that people get put on. They're basically all acting to alter brain perception of pain. They're not doing anything to eliminate the progression of the neuropathy or stop the damage to the nerves. It's kind of like a chemical lobotomy. So patients come in, sometimes they're on multiples of these medications. So they're on the multiples of Cymbalta, Lyrica, gabapentin. They're on their diabetes medication. They're on their statin medication. They're on their blood pressure medication. All of these things are contributing to organ dysfunction, neuropathy. And so you can see how we have quite a clustered web of craziness to unravel when a patient comes in. And you can also see from the list of the things that cause it, neuropathy, that there's not going to be one magic medication, right? Our approach is that conventional approach of just using those brain altering medications to alter your perception and sensitivity to the pain is literally a symptom approach. They're just treating and masking the symptom so that you don't feel the progression of the disease. If you do not handle the cause or the causes, because there can be multiples oftentimes, which can be handling diet, toxins, heavy metals, immune system, autoimmune issues, parasites, yeast, fungus, virus infections, sugars if you're diabetic. If you don't handle those things and then also treat the actual, like stimulate the nerves to regrow and remyelinate with actual treatments, then your disease will progress and you will be in trouble.
Yeah, this is definitely a progressive degenerative disease. So like Dr. Steph said, if we have a diabetic that comes in that has neuropathy, well, of course, we have to address the glucose and the blood sugar issue. And not only that, but we're going to give them therapy in the office that will support healthy nerve function. So there's actually therapies that provide that. We can
and we're not going to be handling the diabetes with just medication that treats the symptom of the diabetes, right? Like the diabetes is a reversible condition that we have to figure out. If someone has neuropathy and part of the reason is they have diabetes, and we have to work to the root cause of why their sugars are high.
Right, exactly. So we want to treat those root causes. We want to give the body what it needs to be healthier. So the nerves need oxygen, they need nutrients. We need to get blood supply so we can get oxygen and nutrients to the nerve. So that's all of our therapy in the office is designed to do that. So we have various therapies, not only in the office, but also at home. Many of our neuropathy patients are also doing at-home therapy so that we can, number one, slow and stop the progression, and then we can watch the nerves actually reverse. We can watch the neuropathy reverse. We can see improvement in nerve function, and that's what we see when we recheck a patient. So we have an analysis that we do, checking these different nerves, and we'll recheck them and compare them to that first examination. And so we can actually see improvement. We can see better perception.
And the goal is to have that nerve function return without the medication, like to not have to be on the medications. Like you shouldn't have to be on an antidepressant or gabapentin if your nerves are actually healing.
Right. Exactly. So it's really, that's our approach, is treating the root causes, determining the causes. We have this list of causes. Let's treat the root causes, and then over time, give the body a chance to actually heal itself. It can heal itself, but we have to give it the right tools. Mm-hmm. All right, guys. So another episode. I hope you guys got some great information from today's episode. This has been Living Health Live with me, Dr. Tom Chaney, and Dr. Stephanie Chaney. If you guys have any questions about today's episode, or you have a topic that you want us to cover in the future, then always, you can always reach us at the office at info@mylivinghealth.com. Once again, it's info@mylivinghealth.com. Office number is 410-216-9180. And we'll see you guys in the next episode.